Hi, good afternoon, everyone from Singapore. This is a session on the ICU experience in other countries. Specifically, we have speakers from India, we have speakers from the Philippines, from Japan, and from South Korea. And of course, the experience that we are talking about is COVID-19. How this will work is that this session is actually being recorded right now. We will ask each speaker to share their own personal as well as their own country's experience on how they have been dealing with this really once in a lifetime pandemic. After the sharing by each of these speakers, we will then go into Q&A. For everyone who is on right now, all you need to do if you have any questions is to type into the Q&A link at the bottom of your screen. We will take it up and answer those questions thereafter. At the same time, this would be like a webinar chat format where after the speakers have spoken, after the questions have been answered, we will just talk about more intricate issues about how each of us in our respective countries have been dealing with COVID-19. So thank you for attending, and I'm really grateful. The Society of Intensive Care Medicine Singapore is really grateful to the 4 speakers that we have with us today. They are all established intensivists, and they're all established clinician researchers as well. And I'll introduce each of them as each of them is going to start their respective sharing sessions. So first up would be Prof. Divatia, a good friend from India. Prof. Divatia is a professor and head of the Department of Anesthesiology, Critical Care and Pain at Tata Memorial Hospital, one of the leading tertiary cancer centers in India, in Mumbai. He's the past editor-in-chief of the Indian Journal of Anesthesia, the past president of the Indian Society of Critical Care Medicine, and of the All India Difficult Airway Association. And his main interests include perioperative care, airway management, hemodynamic monitoring, sepsis, and end-of-life care. And he's got over 130 publications and has been recurrently invited as a speaker at international meetings. So without further ado, Prof. Divatia. Thanks, Prof. Divatia.
Thank you, Jason, and the Intensive Care Society of Singapore for asking me to speak here at this very important meeting in these very dangerous times. So let me give you a brief experience of what's happening in India. So I'll just take you through what's happening in India the next few minutes. So India has now the dubious distinction of having the second largest number of cases in the world. So as of today, we have almost close to 8 million cases and 117,000 deaths. Having said that, the mortality rate is just about 1.5% of the total cases. Now, when this pandemic broke, we knew that we were headed for trouble because India is the second most populous country in the world after China. And we have a population of almost 1.38 billion people. And a pandemic like this was going to really make things difficult for us. And we knew that. I mean, there's things like social distancing and so on would be very difficult in most parts of the country, especially in crowded urban centers and slum areas. We also knew that our critical care resources and our critical care capability may not be up to the mark, and we'd seen what happened to well-established setups in Europe and in the USA. So we were actually really worried. So as you can see that, our number of ICU beds at one point in time were just about 2 beds per 100,000 population, and other countries at about 10 to 15 times as many. And they were still in trouble. The amount of oxygen beds with oxygen capability was just about 120,000 in the country. And we didn't have very good estimates of how many ventilators and how many oxygen beds and how many ICU beds and how many total hospital beds. We didn't have those numbers. So our planning was always going to be a bit on the back foot because we didn't have very precise data, but it was estimated we'd have less than 50,000 ventilators throughout the country, and maybe even as fewer as 15,000 ventilators. We had a very few doctors, and when it came to trained intensivists who would be required to look after critically ill COVID-19 patients, I think, again, there we were in a bit of trouble because we didn't really have a good estimate of the number of doctors or of the nurses, and whatever we had, we were short by as compared to the recommended norms by the WHO. So we were not, we were keeping our fingers crossed and hoping that things would not be very bad. So the strategy that India adopted was, of course, to try and prevent the spread. And one of the things that we did, was a lockdown and, of course, awareness campaigns. We did ramp up our healthcare resources. We'll talk about that a little bit, including testing facilities. And we had to decongest the hospitals. So early on in the pandemic, everyone who turned positive was being admitted to an infectious disease or some other hospital. But very soon we realized that that would just clog up the healthcare system and the hospitals. And therefore, eventually now, a majority of patients are isolated at home, and a few are transferred to specially built, corona care or COVID care centers, which are just small isolation facilities for uncomplicated patients. The lockdown which we imposed on March 24th was probably one of the biggest lockdowns in the history of the planet. 1.4 billion people locked up at home. It had its social and economic consequences. We probably are still facing those consequences, but it did help in some ways to ramp up the infrastructure. So exhibition centers, sporting domes, sporting arenas, they were private hospitals, hotels were converted either into isolation centers or into care centers for isolating COVID-19 patients. Some of them even had ICU facilities. So a number of these came up, and they sort of increased the bed strength that was available to people. Since many people lived in slums and packed quarters, these are the patients who could not self-isolate at home, and they were the ones who would be actually transferred to these centers. We also had a lot of help from other countries and other experience of others, and we quickly drew up guidelines for various sort of things. The Indian Society of Anesthesiologists, the Indian Society of Critical Care Medicine, the All India Difficult Airway Association, we quickly made guidelines to help our members. The government of India also made guidelines, and they had been very proactive. However, the guidelines are still a little controversial because they recommend prophylaxis with hydroxychloroquine even today. They recommend hydroxychloroquine still for the treatment of patients with mild symptomatic disease who are at high risk because of comorbidities and so on. And so hydroxychloroquine still finds a place in the Government of India guidelines. I'm not sure how many of us are still following these very rigidly. And of course, in line with the current data, dexamethasone and steroids for patients on oxygen, and remdesivir, tocilizumab, and convalescent plasma are branded as experimental treatments. In the beginning, we had a problem with personal protective equipment, and that was a big issue because doctors were falling sick. And as you can see in this paper survey, which was published in the IJCC, the Indian Journal of Critical Care Medicine, the red bars are in the early part of the pandemic, before June and July. And you can see that N95 masks we were short of N95 masks, we were short of body covers, we were short of impervious gowns, and things have significantly improved as the time went on. So, and now today, the industry took up the challenge, local manufacturing took up the challenge of manufacturing PPE, and today we are even exporting personal protective equipment. So today, I think we are in a much better position than we were, say, 4 or 5 months ago. And even in Mumbai, where I live, this is some data for Mumbai. We have had, till yesterday, we had almost 245,000 cases. Mortality in Mumbai is slightly higher. It's 4%, much higher than the national average. It's also probably because we've got a lot of referred cases from nearby areas. So in Mumbai, we have over 9,000 beds with oxygen. And today, as of yesterday, 44% were available. So as of today, we are not overwhelmed. We are not struggling to get beds for our patients. ICU beds, we had over 2,000 ICU beds in Mumbai and 20% were available. Almost 1,200 ventilator beds and out of them 16% were available. So we are still functioning at reasonable capacity. If there is a surge, we'll be overwhelmed again, but we are never at a stage like maybe what we heard of in Italy or what happened in the countries early on. But there was a period in between, say, April and June or July, where it was very difficult to get a bed, but that's not the case today, at least in Mumbai and in many parts of the country. So, but what we have learned is, at the bottom line is that what we need is high quality intensive care. We don't have a drug, we don't have a magic bullet, but I think basic care, a good intensive care is what is required. And I think this is reflecting now in the case fatality rate. So when we started off in May, we had a very high case fatality rate of 3.4%, and it was high right up to June. But then I think now we've come down to 1.5%. So we've made progress as far as the case fatality rate is concerned. And as of today, we are seeing a reduction in the number of new cases. So we had a peak somewhere in September when we almost touched 1 million cases, 100,000 cases. We had 97,894 cases on 17th September. That was our peak. We have come down to about 50 odd thousand cases per day, new cases per day. It's a drop, but it's still 50,000 plus cases. So I don't think we are out of the woods at all. We are still, we have to be on our guard. And the problem is we are now approaching the festival season. This is the Dashera season. In a few weeks time, couple of weeks, 3 weeks time, we'll have the Diwali season. We'll have Eid. We'll have multiple celebrations. So we're still very much on guard. So like I said, in India, we've now started coming down as per as the bi-weekly cases per million are concerned. Brazil is also following the same trajectory, unlike what's now we are seeing in Europe, where many of the countries are facing a second peak, or we are facing a second wave. So I hope we continue to maintain this downward trend and we don't land up with a second wave. So I think what the lockdown and other things have done is they've delayed the peak from what we were expecting in June or July to a September peak. And that peak has come down and we've not been completely overwhelmed even when we were at the peak. How are we doing compared to other countries in Asia? So this is the current data as far as bi-weekly cases per million. So we are seeing that Singapore was very high in cases per million. India has now actually slowly gone up right in September and slowly risen to its peak in September. And hopefully we are on the way down and we'll sustain the peak. Pakistan had a small peak. Bangladesh had a small peak, but they are doing much better and they've got many, very few cases. And of course, countries like Japan, Singapore, and South Korea are actually, they've never been, so I don't think they've been as badly off or had as many number of cases as we had. Nepal seems to be showing a slight peak in terms of number of cases per million, but in absolute numbers, maybe not as much. How are we doing in terms of the top countries in terms of cases and deaths per million of populations? It's because we've got a big denominator for our population. The total number of cases per million is not as high as would appear from our total count, right? So if you're looking at, we are just over 5,500 cases per million population as compared to say 26,000 in the US and 25,000 in Brazil. Our deaths per million are also very low, just about 85 as compared to 700 in Brazil and close to 700 in the US and over 700 in Spain. So in terms of cases per million and deaths per million, we haven't done too badly. Where we are not doing well in the amount of tests that we are doing. So we are doing far fewer tests compared to say the United States or Russia or Spain. We are close to what Brazil is doing, but we are still much shorter, much less than what the other advanced countries have done. So, and in terms of compared to our Asian countries, Singapore is doing a huge number of tests in terms of tests per 1,000 of population. We are not doing as many, and other countries are doing even less, right? But in terms of tests per 1,000. We did have a problem, a blip in between when the cases peaked in sometime in September. The amount of oxygen that was available actually was short. We didn't have a shortage. I don't think patients were dying of lack of oxygen, but there were delays in getting oxygen. So So oxygen stores, which would normally last 3 or 4 days or 5 days, were lasting 1 or 2 days. And because of the lockdown and because of transport and logistic issues, some centers were not getting oxygen on time. And that was a small period where there was a small crisis. We have to, morale of the team is important, and it has taken a bit of a beating. Doctors are exhausted. This was this paper which we published in the IJCCM. About 44% of patients had work-related burnout, but and 52% had 26-related pandemic-related burnout. And I think that's happening all over the world. There's a small video to show how in one of these big jumbo centers that we've built, how the doctors and patients are maintaining morale. So this is the Navratri season, where the traditional dance is being done by the doctors for the docs in the PP, the healthcare staff in PP, and the patients are doing the traditional dance for this season. So I think at the end of the day, we've always been there for our patients, but this is the one time we realized that we have to be there for each other. And we have to look after our health and safety as a priority, protect ourselves, for ourselves, our families, and also so that we can continue to serve our patients. So take care, stay safe, and thank you very much for having me here.
Thanks very much, Jiggy. We will discuss some of what you have said later on. The last video is very striking. Thank you. So next up is Dr. Jose Emmanuel Palo. Most of us call him Jeb for short. Jeb is a consultant intensivist at the Medical City, and that's one of the largest private tertiary and training hospitals in the Philippines. The director of the Acute and Critical Care Institute that comprises both emergency medicine as well as critical care services of Medical City. He's also the Philippines representative of the Asia Ventilation Forum and vice president of the Brain Rescue Philippines, an affiliate of the Neurocritical Care Society. He's also actually a very close friend to all of us here, and we have collaborated in both education and research for many years now. So before I hand this over to Jeb, just a reminder for everyone, if you have got any questions, please do feel free to just key it into the Q&A chat site on your Zoom, and we'll answer them later on. So over to you, Jeb. Thanks.
Thank you, Jason. A short disclaimer before I begin. Since there is a paucity of national level reporting, actually, what I can offer here is actually more of a micro-local experience of our COVID-19 response through basically this intensivist's eyes. I can easily tell you that there are 366,000 cases in the Philippines reported, and our case fatality rate is 1.8%. But I am unable to actually tell you what is going on with most of the country because we basically do not tell each other what is happening. Now, before the pandemic actually occurred, a special thing happened to the Philippines. So 2 weeks after the new year in 2020, a volcano south of Manila actually erupted. So in that inset photograph, you can see the ash fall spreading north from that volcano, directly north into Manila and northern parts of the Luzon, which is the northern island. So this is clinically unrelated to COVID-19, but then actually this situation actually became a weird lifesaver for some of us, especially in Manila later on. So I'll get back to that later. So Jiggy was able to tell you what is going on in India. This is how it is where I live. So these long-standing weaknesses being magnified is true for countries, it's true for hospitals. The Philippines has one of the least number of critical care beds for the population it has. And this was the study that was performed by Jason and several of us and published recently. And we were only talking about ICU beds here. We're not even talking about ICU doctors and nurses. And I cannot even tell you how many ICU nurses and ICU doctors the Philippines has, or how many people are actually qualified to take care of ventilators, for example. So that is an issue about critical care infrastructure and manpower. The other thing is that most healthcare expenses are actually borne out of pocket. Any cursory Google search will show you the troubles of our universal healthcare system. I'm not going to say more about that right now. It's kind of embarrassing. Lastly, the crisis preparedness and response models were actually based on earthquakes and floods and storms. Pandemics were basically the black elephant that people never wanted to talk about. This is true for the hospital and the country. So that is our baseline. And now you add here the novel viral pandemic, and people were getting sick from something that we had no experience taking care of. And then you add now hard lockdown, and suddenly the medical personnel and material that you needed to respond to this pandemic could not move about. So that's how it was starting in mid-March. So what ensued should not come as a surprise. It was actually weeks into the pandemic when the national government instructed some public hospitals to become COVID-19 centers. And this allowed better coordination of transfers and centralization of care. In the interim, though, it was the smaller branches of government like cities and municipalities or the private sector that took upon themselves to coordinate the pandemic response as well as they could. Micro-locally, in our hospital, our airborne isolation ICU comprised only of 3 beds, actually. We took over our stroke unit and our intermediate care, and fortunately, were able to convert that into a negative pressure isolation unit. So we were able to make our 3 beds into 16. And then later on, added a few more beds, added telemetry capability to a different floor. So in the end, we went to 20 beds from 3. But due to staff quarantines and the sheer volume of patients, many patients actually had to wait. At one point, an intubated patient could wait in our emergency room for about a week. And the ICU team could be rounding on as many as 10 patients outside the ICU, outside the isolation ICU. So some of the patients didn't even make it to the ICU. Some of them died outside the ICU. One man actually only came to the ICU to be extubated. He had been in the emergency room so long that he actually recovered from his COVID-19 pneumonia. So during this period, we were able to actually see how the formal organizations were not actually working very well. And it was actually the actions of smaller players that were helping people. For example, the leftmost photograph is actually donations of masks that arrived in my apartment, actually, because we were asking for help. Our hospital ran out of N95s or was at risk of running out of N95s. It just so happened that during the volcanic eruption, a lot of people were stockpiling masks for their own use or for the use of their businesses and their employees. And so a lot of people actually had N95s, boxes of N95s lying around. So this actually saved us because we were actually able to help delay our hospital from running out of the most important respiratory protection that we had. So, so basically, these were family and friends and complete strangers that we reached out through Facebook and Viber, whichever way that we could do it. So that was one thing. The second picture there is actually a self-proning protocol that my fellows designed. Was vetted by a loose group of intensivists that we call the Critical Care Super Friends. We are not a formal organization. We all communicate only through Viber. This group was reporting their outcomes to each other and their findings and whatever they thought was helpful. The nice thing about this proning protocol was it was actually picked up as far as the UK. So some portions of the National Health Service there actually started using this SPANC algorithm to help their patients that were not yet intubated. So we're kind of happy about that. So that's Twitter. The third one there actually is a picture of an ECMO consultant from the northern part of Manila, different city. who is actually in an ambulance about to go to the southern part of Manila, where they were going to cannulate a colleague who actually unfortunately been stricken by severe COVID disease. So this expert had been contacted through informal channels also, and so through Viber, this response was coordinated, and even though he had no connection or they had no real connections with that hospital, which is in the southern part of Manila, they were able to help this patient get the care that she needed. So this is how social media actually saved some lives in our country. Now, another thing that I noticed was obviously the rise of what we will call here desperation medicine. During this period, I am sure we all saw or used therapies based on less than peer-reviewed studies. I'm not going to go into that. Desperation medicine costs so many clinical arguments and a breakdown of established practices. I think that many people were saddened by the apparent death of evidence-based medicine in favor of press releases or presidential pronouncements. Now, even operationally, things like antibiotic stewardship seemed like they were being thrown out the door. And now, in my ICU, we are seeing phenomenal numbers of hospital-acquired infections with really weird bugs. I have never seen so many funginias in my career. But desperation also led to some creative solutions to clinical or operational problems. So for example, I found that you can force fit an HME filter into a specific type of respiratory mask. And that second picture there, I'm pretty sure everybody got introduced to the idea of these acrylic intubation boxes that were so in vogue in the beginning, but now they're just dumped in a corridor of our hospital. So some of these ideas were better than others, but I think that the activity pulled the community together actually. And I have rarely felt like that the world was so willing to help. Also, I can report some good side effects, like for example, arts management and critical care education is now very sexy. And now most people know how to prone their patients. Prior to this, last year, if you went around, you'd find nobody proning their patients. Some people would go straight to ECMO if they weren't able to take care of their ARDS patients. Lastly, even the word intensivist went into common use. And so I think I'll have job security for the next few years. So in the face of all that, how did we do? Now, if someone presents a slide like this during a presentation before they report their outcomes, you know it's not going to be pretty. I practice in one of the best resourced hospitals in the country. And so the outcomes that I'm presenting here are the slide that I'm actually presenting to our top management for budget hearings next week. We have been very proud of our critical care outcomes. As you can see in past years and in our non-COVID patients, we outperformed the SAPS-3 Australasian prediction scores. But for our COVID population, you find a standardized mortality ratio of 1.5. More people are dying than predicted. So our early critical care Super Friends Zoom meetings actually showed that a lot of hospitals were faring this way. We were mostly large private tertiary hospitals, and all of us were losing a lot of patients. Obviously, many factors work here. For example, the novelty and the severity of the disease, the overwhelming number of cases, and there were staff quarantines, inability to put patients in beds. All of that put together made these outcomes very bad. I have not really looked into the specifics, but I'm pretty sure it's multifactorial. That number of 57% mortality is very high, and it's also very cold because it does not tell the whole story of the very human tragedies that continue to play out in the ICU today. So I'm glad and I am able to speak at a time that things are not as hectic. So today I rounded in our ICU and we actually had a few beds free, but we could not admit anyone because we didn't have enough nurses. So, but still, it is not as hectic because there are not so many people that are intubated that I need to round on outside ICU. So I'm able to share a little of the experience. I wish I could end this presentation on a hopeful note, but we know that this is far from over. But before I end, I want to thank the junior doctors that showed up and kept showing up because they were there actually at bedside the most. They had, I think, more of the difficult conversations with families than even their seniors did. And they did attend most of the deteriorating patients just because they were there all the time. Critical care was provided everywhere, and a lot of people felt that they were out of their depth. But these junior physicians or junior nurses, the ones that showed up, they kept meeting these challenges head on. So I'm thanking my team. I thank the SICM for the invitation to talk here, and I thank you all for listening.
Thanks so much, Jeb. Wow. Wow. I think some of us in Singapore, we've gotten lucky. We did not, even though we really prepared for this, for the search, we did not face this onslaught of patients, and it's really very humbling to listen to all this. Well, we'll talk more after everyone has spoken. So next up is from Japan, Dr. Moritoki Egi from Kobe University Hospital, another good friend of ours. Dr. Egi is an associate professor of the Department of Anesthesiology and Intensive Care Medicine in Kobe University Hospital. He does lots of clinical research, focusing on clinical epidemiology and outcomes of critical illness, especially in acute blood glucose control, body temperature control, post-operative delirium, mechanical ventilation for acute respiratory failure, and fluid management in acutely ill patients. He's had more than 100 peer-reviewed articles. He's served as a principal investigator in the Japan-Korea Intensive Care Society, Intensive Care Study Group, or the JCOICS. He served as an official member of the Japanese Society of Intensive Care Medicine, Japanese Society of Respiratory Care Medicine, Japanese Society of Anesthesia, and Japanese Society of Cardiovascular Anesthesiologists. And so without further ado, Dr. Egi will share his experience and experience of Japan in dealing with COVID-19. Thanks, Maury.
Hey, thanks, Jason, for the kind introduction for me. And then hi all the audience from maybe from Singapore and from the whole of the Asia. I'm really happy to share our, how can I say, experiment about COVID-19 in Japan. Before chat about the COVID-19, I would like to show a lot of the history for the respiratory ECMO for the last decade in Japan. Japan is, as you know, the very super aging society. This time, the 28.4% of our population is elder than 65 years old, and then about more than the 40% of our population is elder than 55 years old. So our country is a very aging society, and as you know that the COVID-19 is more dangerous in the elderly patient. We in Japan, we have a very unique healthcare system, so-called a national insurance system. The government provide the equal access to the healthcare for every Japanese people. So in the rich people and the poor people, they can access to the healthcare equally. This is a very unique insurance system, even see the whole Asia or whole world. There is some sad story in the pandemic of the N1H1, which is occurred in 2009. Then the respiratory ECMO is not familiar in Japan, and then we do not have any registration system to collecting the information related with respiratory ECMO. And then very few doctors are familiar with it, but the majority of the doctor is, even me, also me, myself as well, is not familiar with respiratory ECMO. And then we do, even though during the pandemic of the N1H1, we try to hook the patient on the respiratory ECMO. However, the survival rate is very low, as 35.7%. This is 2.5 times higher than the predicted from the APICS score. So there is a very sad story for ourselves. So after that, from that time, the education program and the workshop for the respiratory ECMO have been continued until now. So in the 2020, the respiratory ECMO is more familiar than the decade ago. And then we also had the same registration system to putting the data of the patient information and the outcome together from the whole nation. And then this is a recent information related on the COVID-19 in Japan. About 94,000 patients had their PCR positive, and then majority of them is already back to the normal life. And then currently the 5,000 patients are in the hospital. And then this is unfortunately the 1,700 patients were died. So there is now the total mortality fatality rate is 1.8% among patients with the PCR positive patient, PCR positive. This is a capacity of the mechanism. Is a negative pressure room, and then can provide the mechanical ventilation in our region. In the first wave is come in April and May, and then in the one day, our capacity is occupied about 80%. And then we are very close to the running out the ICU bed, which can provide a negative pressure and the mechanical ventilation. Then the government declared a state of the emergency in relation to the COVID-19, which means that all schools had closed, and the prohibition of the non-essential outing from their own house. And then we try to centralize the mechanical ventilation in the hospital for the COVID-19. And then we try too hard to increase the negative pressure rooms in the ward and the ICUs. And then the first wave is gone. And then now our capacity for the hospitalized COVID-19 patient were is now enough for even in the days of the second wave. Now after the N1H1, we really try to organize the supportive organization and then registration system for ECMO or the pandemics like the COVID-19. Which is so-called ECMO net, which support the hospitals carrying the COVID-19 patient. And then we made the registration system so-called the crisis. This is the information from the crisis. The information shows that the outcome of the COVID-19 patient required mechanical ventilation. In this registration, we gathering about 1,000 patients, and then the mortality rate required a mechanical ventilation is about 20%. And then now we know that still the more than 100 patients were on the mechanical ventilation in Japan. Even the second wave is almost gone. This is the outcome for the COVID-19 patient required respiratory ECMO. The survival rate is now about 63.7%, and the mortality rate is 27%. So which is dependent on the when and then what type of the patient we will use ECMO, but mortality rate is very low in compare with 10 decades ago, which is a time of the N1H1. So it is a kind of the, how can I say, the thanks for our effort on the education and the promotion, how to use the respiratory ECMO. We're super aging society, so we are rarely hesitated to use the respiratory ECMO in elderly patient, but some hospitals have to do that, and this is the outcome. Actually, the elderly patient has a high mortality, especially if the patient were more than 8 years, elder than 80 years old. But the crisis data give us very important epidemiological information, and then to inform to the family or patient themselves, or the physicians. So the caring the COVID-19 patient is promote as a very physical and then motor strain, using a PP and then the fear of the transmission to the healthcare providers. So every day we try to decreasing that. So we making a negative pressure room and then zone to making clear where is the red zone and where is the green zone. And then most of the information was gathering by the video and the audio system from each room. Then the video can show which alarm is calling us, or what is the blood flow of the ECMO. So they're zooming, and then we can see the number of each equipment. And then audio device give us alarm sound, and then we can dealing with such a problem using the remote monitoring system, which is some example for our audio system. Even the screen of the mechanical ventilation is also connected to the other screen outside of the negative pressure room, so that we can see how the mechanical ventilator was worked for the patient, and then we try to keep up the lung protection strategy using information for the remote monitoring. After the first wave was gone, huge discussion was happened which drug we should use. And then what we understand is that the lot of the randomized control trial is started and then running, and then maybe every week or every day, the lot of the randomized control trial will come to show up the various result for the various treatment. Therefore, we making a collaboration committee between the Japanese Society of the Intensive Care Medicine and the Japanese Associate with Acute Medicine. And then we try to making the rapid living guideline for the pharmacological therapy in COVID-19. Because the most of the therapy we should provide to the COVID-19 patient was, how can I say, it's similar for the septic patient or ARDS patient. But the pharmacological therapy was a bit different. And then the TV program or the newspaper show up which drug might be good for the patient, might be worse for the patient, whatever. So there is a very huge discussion, make confusion in the healthcare system. So this is one of the reasons why we try to making a rapid living guideline. The mean of the rapid living means that it is a continuously revised guideline, even every month, and renewed and renewed and renewed. And the version 1 was published in September, and the version 2 was published in October. And then now we try to revise at the November, then December, etc. This is a current our recommendation for the 5 of the drugs for the COVID-19 for the every severity of the patient. And then it's this is a rapid living guideline. We renewed the information and then the randomized control trial we get gathered. Then such a recommendation might be changed according to the newly published randomized control trial. So this is our story for the past 6 months. And I'm really happy to see all my friends in the Zooming system. So please stay safe until such a demo was gone. And I'm really looking forward to seeing you each other directly. Thanks.
Thank you so much, Maury. We will discuss more about Japan after the last speaker. And just a reminder for everyone, if you have any questions, please feel free to just type into the Q&A and we will pick it up and discuss this later on. So our final speaker is Professor Sambum Hong. He's from Asan Medical Center and in South Korea. He is a professor in the University of Ulsan College of Medicine. As a clinician as well as a scientist, he's intimately involved in ECMO, in rapid response systems, in ARDS, sepsis, lung transplantation, and also lots of simulation in both clinical medicine as well as research. He's published more than 200 papers, and he's been awarded by the Korean Society of Critical Care Medicine, European Society of Intensive Care Medicine, and the Society of Critical Care Medicine Best Paper Awards, as well as multiple grants by the Korean government. And today he's going to share with us the experience of South Korea in COVID-19. Over to you, Sambum. Thank you.
Thank you, Jason. This is our hospital, but our hospital is a private hospital, so usually not treating COVID-19 patient. We took care of only 50 patients of COVID-19 patient, only 5 patients mechanical ventilation. So usually my presentation is national data, not our center data. We know this is a classification of COVID-19 severity. So from symptomatic, mild, moderate, severe, critical illness, usually as a intensivist treating severe and critical patient, just respiratory rate and saturation kind of thing is important for COVID-19 patient. One paper from our Korean guy published this paper called COVID-19 patient, how to generate screening, which tool is best. They compared the SARS, KICSOPA, and news. You know, the news have included respiratory rate and saturation and oxygen therapy. So AUC curve showed the SARS and KICSOPA similar, but news was best. In this study, in this hospital, they included 110 COVID patients, not very big patient. Anyway, the news score below 4, no mortality. 5 to 6, and more than 7 showed some mortality. So anyway, this paper will suggest news is very important for COVID-19 patient. This paper from China, and you know, the 44,000 patients included, and the severe patient 14% and critical patient around 5%. So COVID patient 20% are severe, very severe patient. As we know, the case fatality rate July, the globally 4%, America 4, European 6.8%, Korea 2.1%. It depends on outbreak and the medical system. This is South Korea situation. The early period, the February, one local area in South Korea, COVID-19 outbreak, that happened. So the case rapidly increased at that time. In one hospital, all hospitals patient transferred to another hospital. So this hospital is designated COVID-19 regional hospital. So around 400 patients took care of this hospital. Our Society of Critical Care Medicine dispatched the critical care team nationally recruited, and 21 intensivists voluntarily involved in this campaign and hospital, and 11 critical care nurses engaged this. So at the first time, the local area, they managed 10 ICU beds. This hospital ICU looks not very luxury, but you know, outbreak situation, it's not easy to make a luxury ICU. Anyway, the case system intensivists joined this hospital, and 1 week later, ICU bed expanded more. So 20 ICU bed took care of patients. So in this area, many critical ill patients was handled by this team. Korean Society of Critical Care Medicine, also we made COVID-19 guideline as our other countries, and we we don't have a very luxury system. Just we are daily recruiting just the numbers. So anyway, we are gathering how many oxygen therapy patients and how many mechanical ventilation, how many patients are taking care of ECMO. Like that, we are doing this. This paper, this data from our colleague sent this ECMO data to me to present this data. So anyway, the September COVID-19 ECMO patient 59, age was 63, and from positioning the percentage before ECMO is only 10%. Very wonder is, the French guys, they applied before ECMO very high rate from position. So there are some cultural difference. The COVID-19 patient, isolated room, lots of equipment. It's not easy to from positioning anyway, but French guys did a big job. How about survival discharge? 46% survive. French showed 41%. Successful ECMO winning 68 and French 63. Look at other papers. The outbreak, during outbreak, very tough paper. In Wuhan, the invasive mechanical ventilation, they applied the mechanical ventilation 100, mortality rate over 90%. How about Italy? The Lombardy also had a severe outbreak. They applied the mechanical ventilation 1,100. Mortality patient 787, so around 70% mortality for mechanical ventilation. So outbreak is very bad. This paper from Mexican, this hospital invasive mechanical ventilation mortality more than 80%. Interesting thing is that this hospital ICU mortality also very high mechanical ventilation, 70%. But during outbreak, this hospital made one ICU in general ward. They applied mechanical ventilation general ward too, but the expanded that room mechanical ventilation mortality was more than 90%. This is a paper from Korea. This paper divided the severity like 5, 6, 7, including 30,000 patients. And 5 means high flow plus non-invasive mechanical ventilation. 6 means invasive mechanical ventilation. 7 means ECMO. So not a small percentage of patients not divided 5, 6, 7. Anyway, total mortality 28%. So maybe I guess for invasive mechanical ventilation mortality around 50%. I think the Japanese data is quite very good, low mortality. How New York? New York also big outbreak. The New York, this university hospital, they included the severe patient only 250 patients. That's 100. They provided invasive mechanical ventilation 200. So mechanical ventilation patient mortality was 50%. So this is my last slide. So COVID-19 patient increased rapidly in society. Almost, 20% of patients are severe patients. But if admitted only hypoxia patient, inpatient, these patients usually progress. 50% of patients are aggravated and need for ICU. So ICU bed needs to be expanded rapidly. ICU capacity, manpower, and equipment also needed. During outbreak, COVID-19 caused high mortality. Thank you for your attention.
Thank you, Sambu. Thank you, thank you. We will now go into the chat session where it will be a no-host, but everything that can be said will be said in this next half an hour. And we will just chat about our own personal experiences as well as our countries, drawing from some of the information that the speakers have been providing us in the last 1 hour. Again, to all attendees, please feel free to just key in your questions in the Q&A, and we will definitely take them. So I just want to begin with a generic question to all of our speakers. And the generic question is just how difficult has it been as an intensivist for you personally, you know, in terms of your morale, your work-life balance or lack thereof, your soul, you know, how has it actually affected you? Or maybe not, yeah. And so, yeah, maybe I'll just leave this open. Anybody wants to start first?
Me first. So we are not a very big COVID-19 patient taking care of center, but only small patient admitted our hospital. But we should make one general word for COVID-19 patient. Many doctors and nurses engaged there. So workloading for because our country also intensivist and ICU nurses not manpower is not very big. So many junior residents and fellows, lots of duty. So COVID-19 is a very tough time for ICU doctors and nurses. Yeah.
Thank you, thank you.
You know, Jason, that question, if you make us relive that experience, we will get PTSD. I'll share a little bit about how it was at the height of it, actually, when the patients just kept on coming. And as you can imagine, if a patient gets admitted with COVID-19 pneumonia, they don't get to see their families either. So they can be in their ICU or in the hospital the whole time, and they may die in the hospital without having loved ones available. And I'm pretty sure everyone has read about this. People have seen this happen. But so that was the kind of stress that, like the moral distress that we were feeling for our patients. But regarding the clinical response, when it was time for me to rotate off at the beginning of this outbreak, and we were getting hammered with admissions, when it was time for me to get off and I finally had like a day to rest, my family thought I was crazy because I wanted to go back. I actually, and I'll share this with you, I actually was in tears because I wanted to go back to the hospital and work more. Of course, you know, I probably would have been useless, but this is the kind of thing that it's unprecedented for me. It's never happened that it's like a war. You just want to go back into battle because people were, you know, that your team was suffering a lot, and it didn't make sense to rest even if you needed to. That's all I'll share about that. I will get PTSD, man.
Yeah. And my wife is a psychiatrist. Will help you. I'm sure a lot of us here can identify with that. Some to greater degrees. Thanks.
So Jason, you know, I just want to echo what Jeff said, that the younger colleagues, the junior doctors and junior nurses have actually borne the brunt of this. And, you know, so they've had social isolation, at least in India, because of the lockdown. And because of initially, at least, even now, the fear of, you know, many of them have elderly parents and elders at home. and they don't want to expose them after they've done shifts. They've got young children at home, so they're having a unique problem. They are actually staying away from home for weeks and months together. And although we try to give them a week off or 2 weeks off after a COVID ICU shift week, it's been difficult. And they have, in addition, they have to do extra shifts because some of their colleagues get quarantined. Some of them have got the infection and some of them have to be isolated. Many of the senior doctors have been laid off work because they've got diseases or they've got comorbidities which sort of we want to shield them. So I think a lot of the younger colleagues have really borne a large part of the brunt. They don't have family support, they don't have a home life, a social life, they're just working. And initially they were seeing people dying, but I think now things are getting better. So hopefully, the trauma of just watching people come in collapse and it's reducing. But I guess it's taken a toll on many of the younger people, and we have to give them their bit for their resilience and their dedication to work.
Right, thanks. Yeah, we always talk about the millennial generation and the Zen generation Ys and the generation Zs. And actually, when things like this happen, you realize that we are not all that different and people will step up and do what needs to be done, right? So it's actually in a way quite inspiring. I think when nursing students and medical students and allied health students, when they enter the schools, very few of us actually think that we will be in such a state in the year 2020. Yeah, so it's just pretty bizarre. Maury.
Yeah. Actually, in April, we are really running out the PPE. Is there no masks and no gown? The provider give me the 1 mask per week. Yeah, so the most of the mask was imported from the China, and then China required a lot of the mask at from the February or May, March, so that we're really running out. And actually, the no information is the cause of the fear. So nobody knows about what type of the virus caused the pandemic. So the young physician, the nurses had a huge anxiety. So I really very keen to get the information from the whole countries about the COVID-19, and then give the lectures, and then to share the information for them to eliminate the anxiety. So this is the first 1 month, 2 months is a very hard time to settle down the anxiety of the healthcare providers, even in the ICU and the world. After the PPEs come from the China or other countries, and then everybody know about the what is a COVID-19, the now situation is slowly settled down. This is my experiment.
Seems pretty common amongst all of us. There's a question from the audience about how we have all been addressing staff burnout, either ourselves or ICUs or hospitals. Are there systemic measures that your hospitals are taking to reduce burnout?
When we recognize that our frontliners, especially the younger frontliners, were having a lot of distress, the hospital actually asked our psychiatry department to check in on them every so often. So they had like a Viber group. They had Zoom meetings. I'm unsure about the process or the outcomes of that. I remember that I was invited to be part of that too, but I got tired of it very quickly and I left the group. But I know that it did help some people process what they were going through, because it is very difficult for um, people that are new to the system or new to intensive care or emergency medicine, and then they get suddenly thrown into this situation. So that's just one of the things that the hospital did. There were also uh, similar programs that were set up for nurses, but I don't think that it was very well picked up.
Right. Thanks.
So Jason, in our hospital, at least we have a counseling service, and we've tied up with professional counselors outside the hospital. Uh, uh, I'm not sure how many have actually availed and what are the outcomes or results of the counseling. At least the ICU staff, the core ICU staff that are working, they seem to be externally okay, but I'm sure they're experiencing anxieties and all that sort of thing. And I guess we'll know what happens once people come out of their shell and start talking and meeting and that sort of thing. I guess even the counselors are not sure what they're dealing with, because it's a different type of anxiety. As Dr. Mori said, now that the PP is in, the anxiety is reduced, but every once in a while someone falls sick, and maybe they get it in the community, because at least in Mumbai and in India, you could get it by, if you're going in a train, or your cab driver may give it to you or something. But every time someone falls sick, there's again a sort of whole new round of anxiety and thing that comes up. And in fact, in the initial part, when people got better, they were fine, they were ready to work. Now with this post-COVID sequelae and the post-information, post-COVID syndromes coming up, again, there is a little apprehension, even amongst the people who sort of recovered and who got away. So they are wondering. And in the last 2 weeks, we've seen people, some of our staff, complaining of fever and complaining of little breathlessness and not feeling like working. So I don't know. Let's just see how this pans out.
In my institution, do you still work? Okay.
No, we're okay.
All right, sure. We also had a health consulting system for the healthcare providers. So if they want, they can easily access to the, how can I say, consultation or the psychotherapy, psychosocial therapies for the moral distress. But mostly we try to do that at the first wave, and the second wave is the communication issues. Like chat issues, if they had anxiety, they ought to come to my place and then chatting issues and then try to solve the problem. So the more communication, more chatting, talk, which is I believe the best drug to make the moral distress better. This is my experiments.
Thanks, Maury. Sambum, you have anything to share?
I think it's not easy problem, and for COVID-19 patients, not only medical professionals, whole country, whole people can affect psychiatry. I think the lockdown also affect a lot of things, but the patient, I've got some news from our nation. Some young guy also suicide during isolation, and in our hospital, one child has COVID-19, but the child should be isolated room, but the parents more anxiety. So healthcare professional has also anxiety. So we have also some consultation system, but anyway, during this pandemic period, not very organized. Everybody has anxiety. And especially very early period, our country has an outbreak. So nationwide, many old people, so chaotic. So nowadays mortality is down and the case is down, a little bit calm down. But anyway, I think this is a big problem. Maybe we can make more solution in the future needed.
Thanks, Sambu. Yeah, what strikes me is that a lot of times when we look at our colleagues, they look fine. But I think it's tricky. They look fine, but they may totally not be fine, right? You use the, what's that called? The Maslach burnout inventory, the actual official questionnaire. And all the studies show it, right? People are officially burnt out even before COVID-19, let alone COVID-19. So yeah, I too am wondering what is the real purpose or use of all these counseling services and all that. I think probably prevention is probably more important, you know, easier said than done. The dissemination of very accurate information, the provision of good PPE, just people holding each other's hands and trying to support each other psychologically on the ground, rather than wait till you have to see a psychiatrist and all that. But yeah, one question struck me while Sambu, you were talking about how this actually affects the whole country. Actually, two questions struck me. The first question is, well, it does affect the whole country, but generally healthcare workers may be hit even more and they may die. So I just wanted to ask that question. Any mortalities of healthcare workers in your countries? I know Singapore so far, none. Any that you know of so far?
Yes, Jason, I think we have over 300 doctors across the country who we know have died of COVID. And they've included the entire spectrum, starting from general practitioners to surgeons, anesthesiologists. A few intensivists have also died. Some have, and many of them been in the young middle age to the older middle age group, you know. So because the very senior people have probably stopped practicing clinical practice, but it's the younger ones, a few young ones who are less than 40 who died, and many in the range of 30 to 50 have probably passed away. So that is a bit of an emotive issue, but you know, and whether they've been seeing patients and who they came in contact with, I mean, we don't know, but we don't know that they've contracted COVID and died during this pandemic.
Wow, 300, that's a lot. And those are doctors, right? Not counting the nurses and...
No, these are just doctors. This is the figures that the Indian Medical Association gave to the government.
Wow. Any in the Philippines, Jack?
I know that there were at least 30 physicians, I think, and a number of nurses that died from COVID-19. And like what has been happening in India, the ages and practices of these doctors were varied disciplines and all over the age range. And it was, we actually took care of a lot of them actually in our ICU. We were getting a lot of the sick ones in the very beginning. And the surprising ones were pediatricians, general surgeons. I know of some emergency physicians, but I do not know specifically of any intensivists that got so sick that became critically ill also. The community is very small. It would be a big blow. But yes, we've had losses in our country.
Right. Thanks, Jeff. There's a question on what the government is doing and endless debates between economy, trying to open up the economy and trying to protect the population from COVID-19. This endless debates thing. Maybe if you don't mind, I start with Jiggy, because we all remember that news that one third of the world is under lockdown, and actually it all started with China and India, right? And you mentioned it, I think it was sometime in March. How was it then to, and as a clinician, as an intensivist, you know, what is your stand? How much should you open up versus protect the population?
Jason, that is a impossible question to answer. I mean, so we introduced the lockdown when we had less than 500 cases, right? And uh, in spite of that, we've reached a stage where we've got almost 7.5 million cases, right? So between March and October. Uh, so we've clearly not been able to prevent the rise in cases or prevent, and we at one stage we were touching 95,000 new cases per day in September. Now, what many of the epidemiologists tell us is that it has had an impact in the sense we've delayed the peak, and we've been able to build up infrastructure in that sort of period, and maybe that's why the mortality is a little less than what it may have been. But there is a huge social and economic cost. I mean, I think that is undeniable. And that social cost is, it adds to the anxiety, it adds to there's no outlet for people, there's no restaurants, there are no theaters, there are no bars, you can't even go for a walk, So in the early part of the lockdown, there's a very intense lockdown. So it's had a huge social and economic impact. And I don't know how to measure deaths saved or lives saved versus, you know, the impact on the economy and how many people have lost jobs and how many people have lost income or reduced income. So I think it's an unending question. Just in pure medical terms, we are now going to the festival season, and all the doctors and doctors association and medical bodies are saying that please do not have large gatherings, do not organize gatherings in public, stay at home and celebrate at home. So from a medical point of view, I guess a lockdown makes sense. But from an economic and social point of view, it's a disaster. So I guess you have to balance one disaster versus the other. And now, we are opening up. Our country has no choice but to open up, otherwise the economy will be completely shattered. And paradoxically or ironically, the time when our cases were peaking in September and we are opening up more and more because we had no choice. In spite of that, we've done well in October. So I don't know the answer, but I guess a lockdown is not an option. At least a nationwide lockdown is not an option. We have what we call containment zones. So if in certain areas of the city, there's a rise in the number of cases, then they'll sort of lock down those areas, what we call containment zones. Those people are not allowed to go out for 1 week, 2 weeks, and other people are not allowed to go inside that zone. And that seems to have worked to a certain extent. So
I think we don't have an exact answer, but for our society, our government want to control new case below 100 cases per day. So still lots of restriction. Among doctors, some different opinion because some doctors agree about our government policy. Yeah, okay, below 100 is the deadline. But some another different opinion because at this time we have some ICU bed and like that. So, but lots of restriction can affect the economy and lots of some social freedom. So among doctors still debate in our society. Yeah. I don't know the exact answer.
Frankly, I think it's an impossible question to answer, right? Yeah.
And the government to push the economy.
Yeah.
Actually, now the Go-To campaign was ongoing. So the government give money for the Japanese population to go out to the travel or eat. So it's a push the economy. The key point is a scientific consideration of the transmission of the COVID-19. So they're wearing the mask and then social distancing or something. So we should know how is a threshold of the transmission. Actually, the Japanese culture is get used to wear the mask.
Yes.
And then not get the mass gathering. this is our culture. So the Japanese population is more likely to push, can be push the economy, but in different country, in the different situation or the culture, the economy, it should be eliminated. So it's up to the how we can dealing the transmission of the COVID-19. So the Japan is now get used to the eliminating the COVID-19 transmission, and then with the pushing the economy. This is a current situation.
Maury, can I ask, while we are still with you, I know that, because we have spoken, and I know that you are quite passionate about mentoring the younger intensivists.
Yes.
So I thought I should ask you this question that has come up in a Q&A, and about how you would encourage the trainee doctors and the nurses, even though they may be anxious, demotivated. It's a whole new type of intensive care now, right? How would you encourage them?
I just say the welcome to the new world. This is a battle with virus and the science. So we should know what is the enemy and how to dealing with it and how to protect from the virus. So we should not have the anxiety. We should use the knowledge, information, and the science as a sword to battle with the virus. This is what I let them know. So fear is coming from the no information, no knowledge. So I try to share the information and how to dealing the transmission scientifically. This is my belief, the way to encourage the younger nurse and the younger individuals in this situation.
Right. Thanks. Thanks. I just want to finish off by asking all of us here a generic question, and it is how do you think COVID-19 has changed our practice, and what's next? Is intensive care going to be different forever? Are we always going to be looking for the second wave, the third wave, the fourth wave? What's going to happen to how we practice for the rest of our careers? Really, what do you think? Over to you. Anything? Yeah.
Me first, I think I don't know exact data, but in my personal feeling, the other viral pneumonia severe patients are decreasing. So maybe in our all over the world, viral other pneumonia will be decreasing, and our center also building a new building for infection. So lots of protection and hand washing is more change the doctors and nurses. Lots of lifestyle is changing. So for intensivist, anyway, many things are changing.
Jason, I think we are now, for a change, thinking of protecting ourselves first. Like I said, we've always been thinking of our patients, but now we are thinking of how do we maintain our good health. And in India, we've never been exposed to a situation like this, at least in some of the Southeast Asian countries, Singapore and Hong Kong, and and Korea, you had these outbreaks of SARS and MERS and all. So you have a disciplined population, a disciplined doctor force, medical workforce, who wears masks and who does these things. So I think India is going to have to completely change in lifestyle as far as masking and gatherings, and even within the hospital taking adequate precautions when working. It's a completely new experience for us. But what I'm really hoping is that intensive care in a country like ours has been at the bottom of the priority for the governments. I mean, they focused on other healthcare issues and public health measures. But now intensive care is going to become a public health issue. And I'm hoping that this will lead to more investment by our governments in public health, in hospital infrastructure, infectious disease infrastructure, and intensive care. Because, you know, we've suddenly realized that, if we don't have this infrastructure, we are going to be completely destroyed when something else happens, or if this blows up again. Uh, so I'm really hoping that it will lead to better health for the population in general. And once our hospitals are better funded and ICUs are well equipped and staffed, even the other diseases will get treated better. And that's, if you may call, the silver lining, if the follow-up action is taken in the right way.
Thanks, Jiggy.
Yeah, the COVID-19, they led the Japanese government to know how important the intensive care are and the intensivists are. Now the Japanese government is realized that the key of their care for the COVID-19 patient was ICU, and then not just equipment like mechanical ventilation or ECMO. The special the healthcare providers like intensivists or ICU nurses are really important to their facility or the solution for their healthcare system. Most likely the government is going to the surgeons or the general physicians, but now the government is realized that. So that the COVID-19 pandemic is a big issue, but I believe that this is one of the turning point that the intensive care or the ICU staffs they're going to the more major part of the healthcare system. So I believe that the situation or the position of the ICU will be better after the COVID-19. This is a really good chance for us to show up our power on how important the ICUs are. This is my thought at this time. So I'm really positive during that pandemic. Yes.
Thank you, Mark. Jeb, you have the last word.
Man, I can't. I can only echo what they've already said. They've said it so well. So I just hope that some lessons are learned, that we don't have to go through this pain all over again. So we all know that this is not going to be our last pandemic. You said earlier on, this is our once in a lifetime pandemic. Unfortunately, I do not think so. So I hope the lessons are learned. That's all.
Thanks, Jeff, and thanks for the reminder. Yeah, so I think I just want to end this session by thanking everyone, including the participants, including those who have asked the very good questions. And of course, to Professor Divatia, Dr. Egi, Professor Hong, and Dr. Palo for joining us. I think this session has reminded us that amidst all the evidence-based medicine, that we see in the published literature, amidst all the eminence-based medicine that we see in the maybe non-published literature, all the fuss that we see on social media, there's a real world out there, right? There's a real world out there that every time we see a statistic on Wordometer or on the Johns Hopkins website, there's a story behind that statistic. There's a story that affects families. There's a story that affects healthcare workers who are caring for the families. And it's just quite painful to hear some of your stories, but at the same time, it's also very inspiring to know that people are doing good work out there and that we are all in this together, even though we may be separated by Zoom, or no, rather connected by Zoom, but separated by seas and lands of thousands and thousands of kilometers. We are doing the same thing. And I think with that, I hope we take this positively and we move on and we look forward to the next pandemic, because yes, you are right, Jeb, this is probably not going to be a once in a lifetime pandemic. So thank you everyone, and stay safe. Take care. Bye-bye.
Thank you everyone.
Bye-bye.